Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice at ETSU's Bill Gatton College of Pharmacy, and this episode is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. Today we have an exciting phase 1 study to talk about, and then a supportive care, maybe clinical pearl to discuss as well. In this issue of the New England Journal of Medicine, there is a phase 1 study of Rezatapopt, which is a P53 reactivator. Now, for a long time, we talked about KRAS as a common mutation, but was really hard to inhibit based on the structure of the protein. There just wasn't a pocket to block the activity of KRAS, which is mutated in lots and lots of cancers. But generally, it's pretty easy to block signal transduction, right? It's easy to block a road. If I want to block a pathway, block a road, I just need to park a car in the wrong way, right? It's pretty easy to block a road. It's much harder to create a road. And so TP53 is the gene that encodes for P53, our body's most important tumor suppressor gene. And P53 mutations are incredibly common. It's probably the most common mutation found in cancer. And if you have if you have TP53 mutations that inactivate P53, then these cancer cells no longer undergo programmed cell death when there is an error in the DNA replication pathway, or if there's a problem with the cell and it's supposed to die, like it turns cancerous, it's supposed to die. That's the way things work. Well, if P53 doesn't work, that doesn't happen. P53 mutations also promote chemotherapy resistance. So many of our traditional cytotoxic cancer cells damage DNA or impair DNA replication, and a healthy cell's response to that is to undergo programmed cell death. And tumor suppressor genes and tumor suppressor proteins produced whose production is facilitated by P53, that doesn't work as well if you have P53 mutation. So finding a way to restore that tumor suppressor activity of P53 is sort of like the holy grail of oncology. If there's a way to do that, suddenly you could restore chemosensitivity to tumors that are resistant or diseases that are resistant to chemotherapy, and then you could allow cells to undergo the natural protections they have to undergo programmed cell death when things don't go right in that DNA replication pathway. So this is a very exciting, it's a phase 1 study. You shouldn't get super excited about a phase 1 study, but we shouldn't get overhyped, but I think we should celebrate this. It's not ready for prime time yet, it's not approved, it's just a phase 1 study. But let's talk about this. So this is from the primary author here is from Memorial Sloan Kettering, New York City. This is not all TP53 mutations. This is specific to the Y220C mutated P53 protein, which sadly is not the, TP53 mutations happen in like half of all solid tumors. But this Y220C mutated P53 is only a fraction of all of these mutations. And so what this Y220C mutation does is it changes the balance of P53 so that it's no longer stable, and actually reduces the melting point of P53 if you have this mutation, and it becomes unstable and it loses its tumor suppressor function. And so what this drug, Rezatapopt, does, they call it a P53 reactivator. It fits into this pocket where that mutation is, and that kind of it's not a covalent binding. It's van der Waals forces, hydrogen bonds, if you think back to like chemistry, freshman year of college. And that basically restores the conformation of the protein so it is able to do what it needs to do. The simple way my mind works, I thought of like a stool, like a 3-legged stool, and like part of one of the legs of the stool has been cut off, and so the stool leans. Well, now it's not a stool, it's a slope. You can't sit on it, you can't rest something on it, but if you're able to patch up that stool, you can push the stool back up the right way, and now you've returned the function of the stool. That's kind of what this drug does. Is it only really works, and it's only been studied in this Y220C mutation. So if you look at all your NGS reports on all these tumors, you'll see lots and lots of P53 mutations. If this drug comes to market and becomes part of standard practice years from now, you have to start looking at what is the P53 mutation. This is just for Y220C mutated P53. Now, this is a, it's a phase 1 study. It's the first time we're studying it in humans. So our goal of the study is to look at, basically what's the maximum tolerated dose. And they studied 150 milligrams, 300, 600, 1150, 1500, 2000, 2500 milligrams daily, and then 1500 milligrams twice daily. So up to 3 grams a day. And they found that there was, they could go up to 1500 milligrams twice a day or 3 grams a day, and there was no maximum tolerated, that was the maximum tolerated dose. And they recommended to go forward with 2,000 milligrams once daily. That's the take-home message. That's the point of the phase 1 study. We found a dose people could tolerate, 200 milligrams once daily. There's a lot of vomiting and some GI upset, and that was mitigated by taking the drug with food. So 2,000 milligrams once a day with food is the dose going forward. That's usually what we'd say about most of these studies. Like most phase 1 studies, we'd say, yeah, this wasn't too toxic. And you don't, there's maybe some signs of activity here. We're looking at specifically patients with this T53 Y220C mutation. The reason it gets an NEJM publication is, one, it had some efficacy, and it's proof of concept that could be really exciting if there are other ways to restore P53 activity in other P53 mutants. This was, it's a phase 1 study. By phase 1 study standards, kind of large, 77 patients. 30% were ovarian, 18% pancreatic, 12% breast, 12% colon. Interestingly, 2 of these patients had a germline TP53 Y220C variant. So 2 of these patients had an inherited TP53 mutation and predisposition to cancer. There were no complete response rates. Womp womp. Overall, partial response rate, the overall response rate was 20%. That goes up to 30% if you just look at those that were on a high, kind of the higher dosing range. It is notable that everyone who had a response, of course, had the Y220C mutation and were wild-type KRAS. If they had KRAS mutated, KRAS mutations in their cancer, none of them responded. So at the best dose, and this would be confirmed in a phase 2 study, you would expect a response rate of 30%, which is okay. It's okay. There was a good amount of stable disease in this study too, so there still could be benefit even if we're not seeing the robust response rates we typically see when we match a drug with a target. We do an EGFR inhibitor with an EGFR mutated cancer. We see response rates usually well north of 50%. The median time to response was 1.4 months, which seems pretty quick. Toxicity-wise, seems pretty tolerable since most of this was GI toxicity, nausea, vomiting, which we're very good at treating. Maybe not something they expected in the study, but taking it with food did help for that. So Rezatapopt, POPT is how this drug ends. So if you thought it was hard to pronounce drugs end in nib or mab, now we may have drugs end in popt, which is the first suffix I can remember of this medication. So this is going to be studied, in a phase 2 study in solid tumors, in folks that have this Y220C TP53 mutation. There's a study going on of this drug with azacitidine in AML. So it's exciting to see this. It is in the publication, and I had it highlighted, and I thought I had it highlighted. But it's of all the TP53 mutations, this Y220C was, I want to say, it wasn't terribly common. So this is still, it's a step in the right direction that we can do this, but it's really only a fraction of all the patients that have TP53 mutations. I want to say it was 9%, but I swear I had this in the publication. All right, I had it highlighted. 1% of all solid tumors have this. It's the ninth most frequent TP53 mutation. So if half of all solid tumors have a TP53 mutation, this is the ninth most common. Of all solid tumors, 1% have this specific mutation. Now, if you take 1% of everyone diagnosed with breast and colon and prostate cancer and lung cancer and bladder cancer and gastric cancer and head and neck cancer, 1% of a big number is going to be a pretty big number still. So there still could be a sizable population of patients who could benefit from this drug. Going to be very interesting to watch how this drug progresses as monotherapy or in combination. There was some anemia with this, but for the most part, it looked to be pretty well tolerated. And of course, the dose needed for effect might be lower when combined with chemotherapy. We'd have to have more phase 1 studies in combination with chemo. So an exciting drug to watch are these drugs that can block this or restore the activity of Y220C mutated TP53. A lot of listeners to the pod, tune in because they're new to oncology and they're trying to get up to speed, or they appreciate quick, weekly updates to keep pace with the onslaught of new information in oncology. Well, if that sounds like you should check out Oncology Insights newsletter, a free weekly email written by fellow Oncopharm Kelly Karlstrom, founder of Kelly C PharmD and the ELO Collaborative Program. Each week she shares practical pearls, ways to think through oncology concepts without just memorizing guidelines, and insights on staying motivated and growing in your practice. It's written by a pharmacist for a pharmacist, and it's easy to read. You can sign up using the link in the show notes. And it was through this newsletter that I found the next topic for this podcast, which is using colchicine for Dabrafenib Trametnib-induced Pyrexia. So Dabrafenib Trametnib, the BRAF MEK inhibitor combination that is pretty has at this point maybe a decade track record history of being used for BRAF mutated metastatic melanoma, causes a lot of pyrexia, and that pyrexia can be refractory to standard antipyretics like acetaminophen or NSAIDs, and can cause a lot of insensible losses and some dehydration, some acute kidney injury. It can all result from these fevers, and it's a pretty sizable reason patients don't take these drugs. And so some researchers at Mayo Clinic in Rochester have been doing some work in the lab, and I don't know how this happened, but they kind of made this observation. Well, let's back up. We know that if you block BRAF, you're using a BRAF inhibitor for the BRAF mutated V600E melanoma cells. You're also blocking wild type BRAF in healthy cells. And there is a workaround, like if you block one exit, people use the other exit. You block BRAF, the cell uses another way to upregulate the MAP kinase pathway. And that's why blocking MEK, another step in the MAP kinase pathway, has this this additional benefit to just BRAF inhibition and blocks some of that MAP kinase upregulation, like some of the non-melanoma skin cancer seen in these patients. Well, there is this disease called familial Mediterranean fever, where there is also some suggestion that there's an upregulation of the MAP kinase pathway. So some researchers in the labs there at Mayo Clinic probably saw that there was a similarity here, perhaps, in perhaps the mechanism behind this Dabrafenib and Trametnib-induced fever, that we really don't know how they cause it. But we do know that for familial Mediterranean fever, colchicine is the drug of choice. And so there's this case series written in 2019 in support of care of cancer. I can't find anything else published, not even another case report published in PubMed if you search Trametnib colchicine. I can't find anything else really but this case series where they describe 5 patients with pyrexia with Dabrafenib Trametnib that did not respond to acetaminophen, and I think all the cases NSAIDs, and some of them were even on high dose, like 20 milligrams of prednisone for a week, and were still having trouble with fevers, having to have dose reduction of their Dabrafenib and Trametnib. And they gave colchicine, and colchicine benefited some of these patients. It doses anywhere from 0.6 BID to 1.2 BID, which is a reasonably high dose of colchicine. One of the patients did have some pretty bad diarrhea, which we know is a side effect of colchicine. Colchicine can also cause some thrombocytopenia. In addition to the diarrhea, we know that it happens. It impairs microtubule activity, so you could see some myelosuppression from potentially high doses of colchicine as well. But all of these patients that they describe were pretty febrile and pretty refractory to standard treatment. So it doesn't look like something that you would go to first line or prophylactically outside of a clinical trial. But it is something. There are some data. There's some bioplausibility. It's a reasonable, looks like, that maybe colchicine could work for fevers that don't respond to NSAIDs. So something that I hadn't heard of this. This didn't come across my radar, so I was happy to hear about this from Kelly's newsletter, and I was able to go find the publication and read for myself. And it's interesting, something that you file away, or I will file away in the recesses of my brain to use some other time when next time we have a patient that's struggling with the fever for this. I'll talk to the doctor and say, hey, maybe we'll try a little low-dose colchicine, see if that helps maintain our dose intensity here so we can keep people on study longer. So I will have a link to that in the show notes. Thank you for listening. You can follow me on X at Trametnib and follow the podcast on social media platforms at OncoPharmPod. And until I talk to you again, remember, doses matter.